Welcome everybody. Thank you so much for coming along tonight. It's really, really appreciated. We were really overwhelmed by the sudden responses from so many people to come along tonight. So clearly this is a topic that interests a lot of people. For those of you who don't know me, I'm Hayley Lethlean and I'm the CEO at Muscular Dystrophy WA. And I've got a couple of housekeeping things that I'll just go through first and just go through the evening, and then we'll get straight onto it. So the format of tonight is, it's pretty structured, but we will have a little bit of flexibility in it. What we do want to really stick to, however, is to make sure that we have a good session of questions and answer time at the end of the presentation. So we're going to really earmark that last half hour of the evening for you to ask as many questions as you want. I hope you all had some food and something to drink. There will be further food and more drinks served at the end of the evening from 7:30, so please stay around and enjoy that. So a little bit about muscular dystrophy. I'm sure most of you know about Muscular Dystrophy WA and what we do. So we're really passionate about our community and about making a difference for our community and their quality of life, many of whom are sitting here in the room. And we're really grateful for you to be here because for me personally, it's such an amazing thing to know that I work for you, and what we do is to try and make a difference to you and for you and your families. We were born out of research. So 50 years ago, our organisation was born through Prof. Koukoulas and his investment into research and his interest in research in neuromuscular conditions. And it's something that I can say really proudly that we've continued to do throughout. We will never just do research, because we really believe that practical help today is what our community needs today. So we will always focus on that. But we have a strong research arm where we invest into scholarships and into research areas. And that leads us to why we are here tonight. One of our research strategies is around collaboration and making sure that there's a translation of research into practical application for our community. And the projects that will be talked about today, absolutely, if they produce the results that we're hoping they will produce, they may have a positive effect on the way clinical practice actually happens going forward. So it's a pretty exciting research project that will be talked about today. I know Adelaide's going to give us an update on a lot of other research that's happening. So that's where we're at. So I think I'm pretty much done. I am going to introduce Graham, who is our next guest speaker of the night. Professor Graham Hall, I have to put my glasses on for this, is the head of Children's Lung Health and the Deputy Chair at the Telethon Kids Institute, and he is a research academic at Curtin University. Graham focuses predominantly on how lungs grow and developed, and the impact that has on respiratory disease and lung health. We've been working with TKI and Graham and Adelaide and Andrew for a couple of years now, through one of our research scholarships to Adelaide, and it is amazing the progress that's happened over the last couple of years. International collaboration is an amazing thing, and we feel very privileged to be part of that. A very small little not-for-profit organisation tucked in little Western Australia in Perth, to be able to have a very small input into something that potentially has big outcomes for communities. So Graham, welcome.
Thanks, Hayley, for that very generous introduction. So, as Hayley said, my name's Graham Hall and I'm the Deputy Director here at Telethon Kids, and so it's my great pleasure initially, and while I'll be talking to you later about our research, but initially to welcome you here to Telethon Kids. I'd like to acknowledge that we're on Whadjuk Noongar Budja, and pay my and our respects to Aboriginal elders past and present, and the contribution that they and their community make to us and our community, and in particular the research that we do here at Telethon Kids. And I'd particularly like to pay my respects to any Aboriginal or Torres Strait Islanders who are in the audience tonight. So Telethon Kids is one of the largest, most respected child health research institutes in Australia. And we have a diverse team of over 500 staff, students and researchers, all focused on one thing, and that's to improve the health and well-being of children and young people through excellence in research. So perhaps one of the biggest distinctions is, unlike a university who also engage in education, our sole focus and our sole mission is around research. One of the things that we've done over the past 5 years in 2012 is that we launched a new strategic plan, and that really was to set the Institute up with a blueprint where we as researchers proactively and continuously engaged with community, with clinicians, with policymakers, and with individuals and their families to improve child health and well-being. Our research crosses 4 major themes: brain and behaviour, chronic and severe diseases, early environment and Aboriginal health and wellbeing. And those names may not mean anything in themselves, but within those we have over 40 different research teams working on different aspects of child health and wellbeing. The blueprint and the strategic initiatives that we've brought to having an engagement with community, I think, is really well typified by why we're all here tonight. So one of the projects we'll be talking about tonight is a project that I'm involved in with Andrew and Adelaide, but also equally with Muscular Dystrophy WA and with Hayley. And it's fantastic to have that living example of research that is really engaging with the people and the end users of the knowledge that may be generated from research, because it's only when you engage with the end users that you end up producing outcomes that the end users are actually interested in. And so for us and for you, that's the muscular dystrophy community, and I'm hopeful that the research that we do will actually translate into meaningful outcomes. I'd just like to let you know that we are filming tonight so that the information that we convey can be distributed by Muscular Dystrophy to the rest of the community. So when you ask questions, we are going to ask you to use a microphone. For those of you who don't feel comfortable asking questions in that forum, there'll be plenty of time afterwards to come and ask us questions one-on-one, and we'd really welcome that opportunity to talk to you. I'd like to acknowledge a few people in the audience. So obviously Hayley, it's been fantastic working with her. Claire Bailey from Save Our Sons, and I'm involved in another project which Adelaide's going to mention earlier, that where Claire has been working closely with some of our researchers, and that's fantastic. Susan Treyer is a board member of Muscular Dystrophy WA. Prof Sue Fletcher, and I'm sure you're all intimately aware of the work that she and Steve Wilton have been doing in really producing, probably for the first time, life-changing treatments for boys with Duchenne's, and Peter Rowe from the Department of Neurology here at PMH. Peter, it's great to have you along. And importantly, and really critically for me as a researcher, it's amazing to be able to welcome to Telethon Kids the members who have agreed to join the community reference group for our project, and some of whom are here tonight, but they are Zai Phillips, Noah Ryan, Jacob Ratinas, sorry Jacob, I knew I was going to get that wrong, Peter Hops, Vanessa Stanford and Michael Truscott. So we're really keen in, as we take our project forward, having them tell us, well, that's a great idea, but it's not going to work, so you better come up with another one. Or that's a great idea, but if you can do that differently, maybe actually it will work and people will engage with what you're trying to do. So we bring to this project our frame of reference. Hayley will bring the community perspective, but importantly the community representatives we have on our committee will bring your perspective to our project. And so as we're engaging with you, if you don't like what we're doing, you can tell us direct. We're pretty robust, we'll handle that. But if you don't want to do that, please do tell either Hayley or one of the community reference groups so that they can say, well, we got some feedback and you're going to have to change this. So with no further ado, I'll hand back to Hayley, and I look forward to talking to as many of you who are interested later on. Thank you.
Thanks, Graham. Oh boy. So on to the next important part of tonight, and I'm just here to introduce Dr. Andrew Wilson. I keep wanting to call him Professor or Mr. Wilson, but that's incorrect. Dr. Wilson is the head of respiratory and sleep medicine at PMH Hospital, and he has had a long interest in neuromuscular disease, and I found out earlier today that Andrew's actually had the interest and been working in sleep medicine and respiratory since 2003. So he's well versed and well skilled to be here telling us what's happening. I think you can do your own introductions in regards to what you're going to talk about, so I'll hand it over to you. Thanks so much, Andrew.
Excellent. I'm going to start by answering a question that none of you have asked, first of all. I'm going to start by why is a respiratory physician and upper respiratory physician, respiratory scientist coming to talk to us about things about neuromuscular conditions? It says neuromuscular, so nerves and muscles. Well, there are very common respiratory complications of neuromuscular conditions. And we view them mostly as complications, which are things we really try to either prevent, or if we can't prevent, manage as best we can, which is why we're interested. Adelaide's going to talk in a lot more detail about what the respiratory complications are. But from my point of view, there's lungs. We see a lot of stuff with lungs. This isn't a lung condition. The lungs are driven by a pump, basically, and the nerves and the muscles run the pump. And sometimes you need to clear out the pump, which is when you cough, basically. And that's the things that basically can lead to respiratory problems in neuromuscular conditions. I'm going to talk about, so in late 2017 and early this year, there have been new standards of care published for both spinal muscular atrophy and for Duchenne muscular dystrophy. And I wanted to talk a bit about those, and then talk a bit more specifically about what's going to be happening as we move down to the new Children's Hospital. And we'll talk about when that is as well. Okay, so I wanted to talk about standards, guidelines, recommendations, and what we now have called care considerations, or considerations as well. And a standard is something that's fairly fixed and rigid that you need to adhere to. So if I want to, for example, market a new bike helmet, it will need to conform to an Australian standard, otherwise I can't sell that as a bike helmet. Similarly, our sleep laboratory needs to adhere to certain standards, otherwise we can't perform sleep studies. So a standard is something that you need to adhere to. There's a consequence if you don't. A recommendation or a guideline is a sort of next level lower down. It's more, we recommend that you should do this. And the sort of thing is, the Australian Dental Association might recommend you brush your teeth twice a day. You're not going to lose your teeth if you don't. Well, you might lose your teeth if you don't, but no one's going to take your teeth away, basically. And the next level down is what you might call a consideration. So consideration might be, these are the 10 things you should consider before buying a waterbed, maybe, or something along those lines. So it's basically, this is something you must do. The next one is something you should do, and the next thing is probably something you might do. And we started out with standards of care, particularly I think in the early 2000s for both SMA and Duchenne muscular dystrophy, and increasingly that's gone from recommendations now towards care considerations. And I'll talk about the reasons for that as we run through some of the new standards of care. And it's not just that doctors don't like being told what to do. All right, so these were the SMA publications. So the SMA guidelines came out late 2017, actually published online late 2017, and this one's actually still in press. So basically they came out in 3 parts, and what I'm going to talk about principally are the respiratory part. But what I'm not going to talk in a lot of detail, because I think what's most important is actually on the next slide. It covered 9 topics. And the topics that were covered were diagnosis and genetics of SMA, physical therapy and rehabilitation, the orthopaedic care, growth and the bone health care, nutrition, pulmonary care, acute care when you're in a hospital setting, other organ systems that might be involved, medications, and ethics and palliative care. And like I said, that's probably the most important thing. It gives you a framework. If I'm looking after individuals with SMA, these are the sorts of things I need to think of and need to consider. These are the people I need to be involved. And I'm not going to run through all of the recommendations for orthopaedic care, growth and nutrition. They are there if you're interested. I want to talk a little bit about the respiratory reasons. And basically, one of the things that's quite useful is they have come up with this idea of a clinical algorithm. Previously, it's easy for guidelines to say, in SMA type 1 you should do this. In SMA type 2 you should do this. They've taken away emphasis from SMA type 1, type 2 to people who are currently non-sitters, sitters and walkers, and made some recommendations about what you should do. But further to that, they've actually come up with what they've called a clinical algorithm to say, this is how you should assess respiratory health, and in line with what you're assessing, this is what you should do about it. So they've put the two together really nicely. So they've started at the top is initially you make clinical assessment, and your clinical assessment is both your asking someone about their respiratory health, but also performing an examination and performing some lung function testing. If you've got evidence of impairment on your lung function testing, or if you've got symptoms, you'll go on and do some further assessment. That might include further lung function testing. It might include overnight testing with sleep study. At that time as well of the further assessment, if you're starting to see some symptoms, you'll do some things around prevention. You'll look at vaccination, particularly influenza vaccination, and other interventions you might start to think about are around physiotherapy, around assisted coughing, particularly if you're starting to see more problems like chest infections. If you're starting to see those problems again and you're looking further with sleep studies and you're starting to see problems during sleep, you're going to start to intervene during sleep with things like non-invasive ventilation, combined with the other things that you're doing as well. So rather than saying for a list, you have a person with SMA, you need to do this then, and this then, and this then. This is more thinking, where does this person sit? What are their issues? What do I need to be thinking about both for assessment, but also for management as well? For Duchenne's, again, late last year, there were 3 papers that came out looking at new, what they called care considerations for diagnosis and management of Duchenne muscular dystrophy. And I'm going to go into the respiratory about why these aren't standards of care and why they're not even probably guidelines and recommendations. But basically this has come out, and in part 2, the one we were interested in for tonight, included respiratory as well as cardiac, bone health and orthopaedic management. And again, I think this is probably the most important area that comes out, rather than going through the details of saying you should do this. It's more having the broad framework of the way you might approach providing care for an individual with Duchenne muscular dystrophy. You have to involve the neuromuscular management and management of the neuromuscular disease, as well as rehabilitation, endocrine management, particularly around things like growth, but also puberty, gastrointestinal management, including the nutritional management, the respiratory management we're going to talk about in some more detail, the cardiac management, management of bone health and osteoporosis, orthopaedic management around joints and contractures, management in primary care, how you involve both primary care and the hospital, emergency management during illnesses, psychological management, and also how you manage transitions of care, particularly that transition from paediatric towards adolescent to adult care. So those are the sorts of things that during your program where you're looking at someone with Duchenne muscular dystrophy that you need to address. This projects terribly, but I don't want to discuss it in detail, but it basically talks about the way they approach respiratory assessments in Duchenne muscular dystrophy. They talk about people in an ambulatory stage, in an early non-ambulatory stage, and a late non-ambulatory stage, and they assess basically what you should do at each time. I think it's a little bit, I don't think it's quite as sophisticated as the approach in SMA, but it's a different disease. They recommend measurement of yearly lung function in the early stages, and the measure they're recommending is what's called forced vital capacity, which Adelaide's going to talk about, which is basically take a big breath in, blow out as hard as you can. We did some work a number of years ago which demonstrated that only about 50% of individuals with Duchenne muscular dystrophy can perform that manoeuvre reliably, and as you get more advanced it gets harder and harder. Similarly, some of the other measurements get very difficult to do as well. So while it's important they say initially once yearly and twice yearly assessment of lung function, there's still some uncertainty about what the best way of doing that is, and there are some real deficiencies in the recommended tests. They also recommend sleep study with capnography, which is measurement of carbon dioxide. if there's problems, or later on, yearly. The problem that they have with that recommendation is there was a paper published last year which looked at a number of US sites and looked at sites that were actually in a research network and how many of them actually had access to sleep study. These are sites managing people with Duchenne muscular dystrophy. Only 35% actually had access to, or easy access to sleep study. So you can put it in as a recommendation, but you're recommending it to people who can't actually necessarily do it at the moment. What's really interesting though is this, where we get to in the late non-ambulatory stage, where they've recommended when you should introduce assisted ventilation, and they say preferred non-invasive via mask, because some centres aren't very well set up for non-invasive and might actually have to do tracheostomy and invasive ventilation in that setting. And they've said, yes, fine, if you do a sleep study and it shows hypoventilation, so insufficient breathing during sleep, which is what we generally recommend as the time to introduce this therapy, you should do that. But because lots of centres can't do that, they've also said, well, if your lung function gets to less than 50% predicted, you should go on to nocturnal non-invasive ventilation. This is the current 2017 recommendation. And most of us would balk at that a little bit, because we see many people who have lung function at 40 to 50% who have no sleep disordered breathing and no symptoms. And the evidence that they use to base this on does not say, if I introduce non-invasive ventilation in this person, it will lead to a better outcome. It basically says, if my lung function is that low, it's a bit more likely I might have a problem during sleep. So it's 2 steps removed from actually useful evidence. So this is why this can't be a standard of care, and it can't even really be a firm recommendation, because there's a lack of evidence. And that's one of the reasons we're doing this research. We need better evidence about what we should measure and when we should measure and what it means, and what it means for future care. We need better ways of determining who should have difficult to get investigations such as sleep studies and when they should get them, and what measurements might actually predict that, rather than relying on something that will capture a lot of people at 50% who do have hyperventilation, will capture a lot more who don't, and will provide a lot of unnecessary burdensome treatment. So that's one of the reasons we're looking at this research here now. What I want to move on to now, before I run out of time, is the New Children's Hospital. So the New Children's Hospital, if everything goes to plan, we will be moving into, initially towards the end of May, with a final move date of the 12th of June. Now, I've said that to a few of my patients recently. I said to one of my boys who I look after, who's on CPAP at night, so that he was going to have another sleep study before we moved hospitals. So he said, oh, that's okay, sometime within the next 2 years then. And another girl today I saw who's got cystic fibrosis, who's going to be admitted within the next couple of months. We said, look, it'll be your last admission in the new hospital. And before we moved to the new hospital, she said, oh yeah, there's probably about a 10% chance of that. There's a fair amount of cynicism around that this is going to happen. It is going to happen. We can't say exactly when. Okay, I'd like to be able to say to you now, 100% guaranteed lead-free. I don't have that information. However, we're all working forward towards a date of final move date, June the 12th. So, the July Neuromuscular Clinic will take place down the road at Perth Children's Hospital. So the differences that you're going to see in Perth Children's Hospital is a brighter place. It's pretty well guaranteed the lifts are going to work, as opposed to the current institution, where we have one breakdown a day at the moment, and we have an on-site lift technician. The structure will be a little bit different, and one of the things that's that is a little bit different is office areas will be separated, outpatient areas are in one building, inpatient areas in another building, so much clearer separation between those particular areas. This is a view of the atrium. I'm going to flick forward to another view of the atrium here. Some beautiful sort of artwork, these wooden animals around the place. It looks great. It's a really beautiful environment. I've only seen it with no people in it, but I assume it'll be nice with people in it as well. Up the top there, you can see that blue shining thing is actually these fibre optic lights. So as you walk under, the colour changes as you walk past, or as you come past under a wheelchair. The colour will change as you go past. On the first floor as well, there's these cameras that will capture you as you go past and turn you into a robot and project you up on the wall and things like this. It's amazing. It's going to be a much more pleasant environment. There's going to be a food court on level 1. I assume it's going to be having 100% healthy food and nothing fried, although one of the places did say it was a burger bar. So there's going to be much more options for food. Importantly, there's a lot more parking, including ACROD, particularly for ACROD parking. There's a lot more ACROD parking than we have with the sort of odd bay that we have access to at PMH at the moment. So that's going to be a really important thing. I'll flick on and show some of the other areas. That's another part of the atrium there as well. The outpatient clinics. When you come to outpatient clinic, you can go up to the desk and say, I'm here. You can also just scan your barcode. And your barcode will, like, going to your shopping, you don't actually have to go through the till. You can actually go through yourself and scan everything. You can scan yourself in. You'll get an update on your mobile phone when you'll get an update on the wait time. You'll get an update on your mobile phone of when the room's ready, and you'll go straight through into a room. So you don't have to wait in this waiting area outside. You can be in the food court, you can be upstairs, and you can just go through to your room when you're ready. So that's hopefully going to work really well. Inpatient wards are noticeably different as well. Most of us who've worked in health for a while are really used to the idea of this nurses station. It's this barrier, between us and the outside world. And this looks a bit different, so it's going to take getting used to for staff. It's probably more so for staff than it is for patients as well. But you can see the ward's much more open, and importantly, 95% of rooms are single rooms as well, but with really good visibility, if necessary, from the nursing stations. And the ward rooms, there'll be a bed underneath that monitor there, but you can see that as a lovely. All of the inpatient rooms have their own window, and all of them basically have a view. There's a parent bed which sits and fits in that area there. There's an ensuite in each room. So inpatient-wise, if you do have to have an inpatient admission, accommodation is a lot nicer at the new hospital. It's another clinic area as well, and you can see that sort of fairly broad open plan. If you are an inpatient, if you're a parent, your child's in hospital, you have access to slightly nicer sort of parent lounges and parent breakout areas than we have now, with a wonderful view of Kings Park. There's also megazones being replaced by a new concept, a thing called Fun on 4. And Fun on 4 has this fabulous outdoor area as well as an indoor area as well, so it replaces megazone. It's got the indoor areas that will have all of the things that megazone does. It's also got this thing called a beanbag theatre. It's got an outdoor theatre. So the kids who are in hospital, particularly if they're in for a more extended period of time, potentially there's a lot more to involve them as well. All of the other things like radio lollipop and things are still there as well. And there's a family resource centre on the ground floor, and there's also an Aboriginal family research centre on the ground floor as well that will be staffed during the day as well. So from an accommodation point of view, I think it's going to be much better. I don't have, unfortunately, pictures of the sleep clinic, sleep unit, and I couldn't get pictures of the outpatient rooms themselves, but they're very well set out. Importantly as well for us, the sleep clinic has rooms with built-in hoists, so we don't have to go and get mobile hoists. The rooms, the inpatient rooms, there'll be sufficient rooms with mobile hoists. The bathrooms on the wards have built-in hoists and things as well. So for those who have impaired mobility, there will be significantly improvement to the accommodation at PCH. So I'm going to leave it there. And as I say, we've got plenty of time for questions afterwards. But I think it is an exciting opportunity. What we need to make sure is that we deliver the standards of care that are worthy of moving into this fabulous building. Okay, thank you.
Thanks, Andrew. That's pretty exciting. Piper and I did our induction in there in February 2017. So we went through this beautiful, brand swanky new hospital, and I think Piper did a re-induction last week. So yes, it's very exciting. And thank you very much for that update on clinical care and recommendations, Andrew. That's fantastic. I think it has applicability across all age groups. I'd now like to welcome Dr. Adelaide Withers. I have to get my glasses out again for that. Dr. Withers is actually a recipient of an MDWA Team Spencer Scholarship Our initial, partnership started with TKI through the scholarship from Team Spencer, which is from Rick and Ruth Stevens, who dedicated some funding particularly for research in honour of their little boy Spencer. So we're delighted to have you as one of our scholarship recipients. Adelaide is a paediatric respiratory and sleep doctor at PMH with special interests in neuromuscular conditions and the effect on respiratory health. Adelaide's currently undertaking research through Telethon Kids Institute and Curtin University. Thank you, Adelaide.
Okay. All right. Can everybody hear me? Okay. So that's a bit of a tough act to follow with all these amazing pictures of our new children's hospital. But I'm going to change tack a little bit and talk about some of the current research that's happening in WA in neuromuscular conditions. So tonight I'm going to be talking about respiratory health and lung function in neuromuscular conditions, and specifically focusing on some of the research that has happened in WA and where we're going to from here. So I'm going to talk a little bit about the effects on respiratory health of various neuromuscular conditions and how they can affect our lung function testing. I'm also going to talk about some of the clinical research which has already been undertaken, and I'm going to have a bit of a focus on a particular spinal muscular atrophy and Duchenne muscular dystrophy and some of the clinical trials that have happened in this area. So just for a little overview, when we're talking about paediatric neuromuscular conditions, there's quite a few different conditions which we're talking about. And there's various groups of conditions, and they can affect any part of your spinal cord or the muscle fibres themselves, or even the nerves travelling to your muscles. I'm really going to be talking about myopathies, which affect the muscle fibres, and also talking about the various muscular dystrophies, which also affect your muscle fibres. There's lots of different effects on your respiratory health if you have a neuromuscular condition. And most of the problems occur with your respiratory system because the muscles required for breathing are weaker. And you can see here on this picture, you've got lots of muscles on the outside and inside of your chest wall, which help your chest expand. And if your muscles are a bit weaker, they get tired more easily, and it's much harder for your chest to expand as much as we would like it to. It also makes it harder for your lungs to actually deflate because your muscles need to contract to push the air out once you've taken a big breath in. So what happens is your chest wall can't expand as well as we would like, which makes it harder for your lung sacs to inflate. This means that your chest is not expanding as well, and you breathe less oxygen in and you get less carbon dioxide breathed out. This is a real problem for people when they're asleep, because when you're asleep, your muscles all relax, so your muscles get even weaker, and that happens to everybody when they're asleep. So when Andrew was talking about hypoventilation, that means that you can't get enough carbon dioxide out, and we usually see that happening first when people are asleep. Some of the other problems that you can get with a neuromuscular condition are made worse by scoliosis, which is when your spine starts to bend. It's very common in people who have weaker muscles. And you can see from that x-ray there, unfortunately I don't have a laser pointer, that person has quite a big scoliosis, quite a big bend in their spine, and it really squashes your lungs down, makes it even harder for them to expand. And the weakness of your muscles can also make it very difficult for people to cough. So when you cough, you actually need to be able to take a really big breath in, expand your chest, and then you need to be able to cough and push those muscles really hard to blow the air and any secretions in your airways out. And you can imagine if your muscles are weaker, it's quite difficult to cough effectively because you can't take a really big breath in and it's hard to push the air out forcefully. This can mean that people with neuromuscular conditions can have trouble with chest infections because they can't clear secretions out effectively. It also means that if you have difficulty swallowing, if you've got some weakness in the muscles around your airway, that can also contribute to chest infections because it can be quite difficult to swallow and breathe at the same time without getting either food or liquid or even sometimes saliva actually into your lungs. That's called aspiration. So all of these things can lead to chest infections, which also affect your lung function. So people who have neuromuscular conditions, often because of the reduced lung expansion and weak cough, can have lower lung function. And there's lots of different lung function tests we can do. It really depends which condition you have as to the abnormalities we see in your lung function testing, and it can be affected by the different kinds of muscle groups that are involved. So some people will have very weak muscles for breathing in and out, which can affect their lung function, whereas other people with different conditions might not have as much involvement in those muscles and their lung function might not be as affected. So we've got a lovely picture here of Graham doing some lung function here. One of the lung function tests that we often do is called spirometry, and this can measure the amount of air you can breathe in and breathe out. And one of the problems with this test is it's quite difficult to do if you've got weak muscles, because as you can imagine, it's quite difficult to take a big breath in and blow out. And the test which is often done is called forced vital capacity, and this means you have to take a big breath in and breathe out really hard and really fast, which, as you can imagine, is quite difficult if your muscles are weaker. So one of the tests we prefer to do is called a slow vital capacity, where you still take a big breath in and breathe out, but you do it much more slowly and it's not a forced manoeuvre. And we know from research that this is a much easier test for people to do if they have a neuromuscular condition. We can also measure how much air is in your lungs with a different test called multiple breath washout, and the child in the photo down the bottom is having this test done. And one of the reasons this is a really interesting test is it's very easy for younger children to do because you don't actually need to cooperate very much. So we can do it with a face mask or even a little snorkel which goes in your mouth, and children just breathe in and out normally and they don't actually have to do much cooperation for the test. So one of the reasons we're including this test is traditionally younger children can't do a lot of these other tests. So this one might be a good one for us to study. Some of the other lung function tests we can do try and measure the strength of your muscles. And there's a number of different tests we can do. One of them is called maximal respiratory pressures, or MIPS and MEPS. And this looks at how strong your muscles are when you breathe in and breathe out. And the picture at the top there is of a child doing a MIP and a MEP test. And some people who might have been to our clinic before may have done this test. I think it was 2013 that we stopped doing the MIPS and MEPS and changed to a different test. And the problem with this test is it's often quite difficult for people with neuromuscular conditions to perform, because you need to form a really tight seal around the mouthpiece. You need to be able to breathe out quite forcefully, and it can be quite uncomfortable. So it's really dependent on how weak your muscles are if you can perform this test well. So we use a different test called a sniff nasal inspiratory pressure. And the picture here of this little girl down the bottom, it looks like she's got something stuck in her nose. This is a really good test for doing your muscle strength because it's quite easy to do. Everyone has sniffed in during their life, so people know how to do it. It's quite a natural manoeuvre to do. And what we do is we put a little plug in one of your nostrils and we say, take a big sniff in as hard as you can, and that's all you have to do. So you do a big sniff. And this is a great test because really young children can often perform this test really well. Another test we can do for your muscle strength is called a peak cough flow, where we get you to just cough into a tube. This is a really useful test because it can help us predict whether people may be at more risk of having chest infections, because it can indicate that your cough is a bit weaker. Okay. So I'd like to move on to some of the clinical research which is being done in Western Australia when we're looking at neuromuscular conditions. And I'm going to talk about a few studies. The first one is looking at the benefits of the standing wheelchair for young people with Duchenne muscular dystrophy. I'm going to look at a second study which explores the well-being in youth with neuromuscular conditions who are wheelchair users. And I'm going to talk very briefly about our study, which is looking at long-term lung function in children with neuromuscular conditions. So some of you may be aware of this study. This is being conducted by Dr. Jenny Downs, and currently we have 13 patients enrolled. This is a really fantastic study where she's looking at the powered wheelchair standing device. So as you can see here, this is one of our participants, and he's in his standing chair. And this is a really important study because it allows people with Duchenne muscular dystrophy to stand and still be able to move forward while they're upright within their wheelchair. and I'll see if I can get this to work. This is a fantastic little video showing you how you can actually move from a sitting position to a standing position in the chair. So let me just see if I can get it to play. Oh, there he goes. So while you're actually sitting in the chair, just with the press of a button, the seat actually moves and moves you to a standing position, and then you can actually move back down again, back into a seated position. And the chair can actually propel forwards and backwards while you're moving it from sitting to standing. There he goes. Now he's sitting back down again. Okay. So there's a very wide range of domains that they're looking into to see what the benefits of using the standing chair are in this study. And one of the great things about using the standing chair is it often avoids the need for transfers because you don't actually need to get out of the chair to move to a different position. One of the benefits of using the standing chair is that you can spend more time in a standing position, and this actually has a lot of benefits for your bone health and also can help avoid things like contractures. We're still investigating what the respiratory effects of using the standing chair are, but it's thought that this may actually help improve lung function with more time in the standing position, and there may be beneficial effects on bladder and bowel function. One of the things that we were really interested in looking at was the quality of life, and a lot of the people who use the standing chair reported there was a big impact on their quality of life because it allowed them to participate in more activities. One of the things that a lot of the young people reported was it was great being able to interact with people at eye level because they're actually in a standing position, and this allowed them to participate in a lot more activities than they could in their usual sitting chair. Another thing that was a good benefit was it gave people a lot more independence, and a lot of people reported that they could do more activities, they could do things by themselves because they didn't actually need to get out of their chair to do them. So Vivian Travalos has been looking at the well-being in youth who are wheelchair users with neuromuscular disorders. And she's really looking at a wide range of domains of health and well-being. And this is involving people aged 13 to 22 who are wheelchair users and have a neuromuscular condition. So she's looking at a wide range of domains including academic achievement and family support. And really interestingly, she's found that a lot of the young people reported very high quality of life and actually better quality of life scores than people who did not have a medical condition. And the highest predictors of whether you had good well-being were your family support. One of the things that we found from this study was that a lot of people who were using wheelchairs reported sleep problems and a lot of discomfort at night, and that's something that we need to look at in much more detail. There are also quite a few people who reported daily pain on a frequent basis, and this is often due to musculoskeletal complications. So really, this is ongoing research where she's still looking into whether things like supports in your family environment and how they affect our well-being. So the study that we're doing is looking at lung function in people with neuromuscular disorders. And we're looking at a wide variety of domains such as lung function tests, motor function assessments, clinical factors and quality of life measures. And we're using these tests to see if we can predict when people start to develop hyperventilation and need treatment with non-invasive ventilation. As Andrew mentioned, we don't like to do sleep studies because there's lots of reasons that people can't access them. Some people find them really uncomfortable. And if we had other tests where we could predict that someone needed a sleep study, that would be really useful. One of the main reasons we want to do this is we want to find what are the best respiratory tests for us to measure for use in clinical trials. And I'll talk a bit about that in a moment, why that's so important. So we've actually gone back and looked at our lung function in our neuromuscular patients from 2013 to 2018, and we've combined that with some pulmonary function tests from one of the hospitals in America, which is the Stanford University's Lucille Packard Children's Hospital. And we've looked at a lot of our data to find which are the best lung function tests for us to use in our neuromuscular patients. And part of the research we're asking our patients to be involved in now is looking at these lung function tests and figuring out which ones are the best ones to use. I wanted to talk a little bit about spinal muscular atrophy. And this is a condition where people have a mutation in their survival motor neuron 1 gene. And there's 3 different types of spinal muscular atrophy in children: type 1, type 2 and type 3. So you can see these 3 very cute little children here with spinal muscular atrophy. And I'm sure a lot of people have heard about some of the clinical trials which have taken place in spinal muscular atrophy. So as Andrew mentioned, there is a consensus statement about caring for patients with spinal muscular atrophy. And the reason I wanted to highlight this is all of the current clinical drug trials are actually based on these guidelines that have been published. And they all use motor outcomes or ability to move as the primary outcome measures. That means that none of these studies are actually looking at lung function or respiratory health as indicators of whether these treatments and medications are useful. The only outcome measures that they have looked at that are respiratory are some lung function tests or time to use ventilation. And as we've already discussed, the lung function test they're using, the forced vital capacity, is actually not a very good test, particularly in children. And a lot of the papers looking at these trials have highlighted that given that a lot of people with spinal muscular atrophy have respiratory health issues, that's actually something we need to be looking at to look at whether treatments are effective. So there's a lot of different potential targets for treatment for spinal muscular atrophy, and I'm going to briefly touch on a few of them. One of the emerging areas is gene therapy, medications which increase your functional protein, also neuroprotective drugs which protect your nervous system, and drugs which can affect your muscle strength and function. So there have been some recent trials in gene replacement therapy, and this really is a very new treatment where they're using genes in mice to try and correct the genetic defect. And the initial trials have been quite promising in mice. There is a current clinical trial, although it's not being run in Western Australia, where they're trialling a drug in humans, and they're currently enrolling patients with type 1 spinal muscular atrophy. And these are very young children, 27 days to 8 months of age, with type 1 spinal muscular atrophy, and they've been very promising effects with their safety of the drug, their survival and their motor function. I'm sure many of you may have heard of Spinraza or nusinersen, which is a medication which is used at the moment in type 1 spinal muscular atrophy. And this drug works by increasing the amount of protein in the patients who've got spinal muscular atrophy type 1. It's well tolerated, and all the drug trials have shown no safety concerns. And there have been very promising results with improved muscle function 9 to 14 months after their first dose. So the first clinical trials in people involved 20 babies with type 1 spinal muscular atrophy, and there were significant improvements in their motor function. So these children with type 1 were not able to sit prior to the nusinersen, and after the nusinersen, children were usually able to sit, and some were even walking. And this is a picture of 2 children who were the same age with type 1 spinal muscular atrophy. The child at the top was not enrolled in the trial, and the child in the bottom picture was, and you can see this child was actually able to ambulate a lot better. And the good thing about the results so far is it doesn't seem that there is a plateau to these effects, so children continue to improve. There were further clinical trials in children with type 1 and type 2 spinal muscular atrophy, which again showed improvement in their motor skills and very favourable safety profiles. Because of these results, the expanded access program for type 1 spinal muscular atrophy was rolled out. So at the moment, children with type 1 spinal muscular atrophy who are in the initial trials can continue to receive this drug, and it's been approved by the FDA. At the moment, we're still waiting for it to be approved for children with other types of spinal muscular atrophy. And again, one of the reasons we really need to do more research is we can't measure at the moment whether there's an improvement in respiratory function because we don't know which test to do. There are other drugs in development for spinal muscular atrophy, type 1, 2 and 3, including some oral medications, some neuroprotective medications, and also drugs targeting muscle function. And if you are interested in any of these trials, if you look on the Treat NMD website, they have the details of these trials. Okay. I'd also like to talk about Duchenne muscular dystrophy. Again, on the Treat an MD website, there are a very large list of clinical trials which are being run in Duchenne muscular dystrophy, including various oral medications, gene therapy, cell therapy, stem cell therapy, and the exon skipping genes, which I will speak about briefly. Again, many of you may have heard of Sarepta, especially we've got Sue in the room, so integral in developing this drug. This is a really exciting therapy which actually works by skipping over the genetic mutation so that you can make more of the protein which is deficient in Duchenne muscular dystrophy. At the moment, about 13 to 14% of patients with Duchenne muscular dystrophy would be eligible to receive therapy with Sarepta, because you have to have the right kind of mutation for it to work effectively. In 2016, there was an accelerated approval from the Drug and Therapeutics Administration because of the results of the clinical trials. And this drug has been shown to increase the levels of the dystrophin protein, as well as possibly stabilising people's ambulation. So the outcome measures that they've looked at in these trials have been the amount of dystrophin protein you can make and the effect on ambulation. And we do know that this drug works. It does increase your dystrophin levels quite substantially. One of the other outcome measures of this trial was looking at the effect on ambulation, and the patients who were treated had a significant increase in the distance that they could walk, and there was lower loss of ambulation in the patients who were treated. Interestingly, they also showed there was a slower decline in the lung function in the patients who were treated. The problems with this study are, firstly, the tests they used were the forced vital capacity and the MIPS and MEPS test, which we know are not good tests for people with Duchenne muscular dystrophy. They're very difficult for them to perform, so we don't really know what the effects are. These people who were in the trial did have a lot less loss of their lung function, but there was actually no control group. So they just looked at a bunch of historical data and said, this is how much we think people's lung function would change over this time, and compared that to the patients who were treated. So again, this is highlighting we do not have any respiratory outcome measures which are well validated for use in clinical trials in these patients. And that means that we can't actually do our clinical trials and know the effects on their respiratory health. And this is why our research is really important, so we can determine which lung function tests we should use in future clinical trials. And that will allow us to advance treatment and find new drugs and new treatments that we know will improve people's respiratory health. So I really wanted to thank everyone for coming tonight, particularly to our families who have participated in our research so far, to Muscular Dystrophy WA for all of their support and their funding, to my supervisors Graham and Andrew, and also to our research team members Rebecca, Jasmine and Tolu. So thank you very much.
Thanks, Adelaide. I'm sure that was a lot of information to many people, so I hope it hasn't been too much of an information overload, but it's information that clearly we need to be sharing more with our community. We're going to move on to, we were going to have some questions, but we're going to move directly on to the next component. Graham's going to actually introduce the study that Adelaide and Andrew are actually working on, just to give you an understanding of everything that's been identified in the past couple of presentations around what the gaps are, what the aim is of the project that we're going to run. So, Graham, you ready?
Thanks very much, Hayley, and I hope you're all coping and you're not falling asleep yet. So I'm going to give you a brief overview of the project that we've been doing for a little while, but will hopefully now be expanding. As Hayley mentioned, we started this with a little bit of support from Muscular Dystrophy WA and Team Spencer, supporting Adelaide to commence her Masters. And from that, and in the words of Paul Kelly from Little Things, Big Things Grow, we got some data and applied for some funding from the Dutch parent project. So I'm sure you're all aware of the parent project. And so the Dutch parent project in the Netherlands had an open call for research which we found out about just before it closed. We very rapidly applied and found out at the end of last year that we were awarded 2 years of quite significant funding. I think initially when you think about that, there are not many not-for-profits like Muscular Dystrophy or even Save Our Sons who will invest significant amount of money in research happening somewhere else. There is always strategically a desire to want to foster research in your own community, and I understand that completely. I've been on boards where that was one of our strategic aims. For a not-for-profit foundation to decide that they want to invest in research happening from the Netherlands to Australia, so you will recognise that that's not just a short stroll down the road, is pretty amazing, and I think is a reflection on the team that we've brought to this project, and perhaps a recognition that the approach that we're taking is the right approach. At least I hope that's what it means. So you will have seen from what Adelaide and Andrew have talked about a little bit why we're doing this study. We have a range of conditions with progressive muscle weakness, and through that we have a progressive worsening of breathing. And then from that flows a whole series of complications. Andrew highlighted, I think, probably the key issue there, that these are complications of a neuromuscular disorder. So if they are identified, and they are identified early, and we use the right measures to identify them accurately, theoretically we can prevent those complications from happening, either through new drugs, through drugs that might treat respiratory conditions but maybe not treat the underlying neuromuscular condition, or through other interventions that will delay the impact of respiratory complications. And so our focus has really to be, how can we identify if there is a disturbance in sleep early? Because when we can do that, that means that we can start new trials. So many of you probably have heard of, know of, or are using cough assist devices. There is no evidence that cough assist devices in the context of a clinical trial benefits individuals with neuromuscular conditions. Anecdotally, patients who use these say that it improves their life. On a broad scale, when to use it, how long to use it, or what to use them, we actually don't know, which creates a great big grey area as to who should be getting them, when should we be prescribing them, and how should we be prescribing them. And of course, they come with their own burden. They cost funds that have to be found from somewhere. They require children or patients to use them, and so we don't want to be creating burden unnecessarily. So one of the things we're trying to focus on is, can we provide that evidence so that when Andrew and Adelaide or Peter see these patients, individuals with neuromuscular conditions, they can say, well, we've done this thing and therefore we think that this is the best approach, or we've been looking at this and we probably don't need to be doing that just yet. So what are we aiming to do? So I do lung function, that's what I do. I measure stuff in the lungs, and so we're really looking at which is the best test to use to identify hyperventilation, so those problems that occur during sleep, as the first marker of things really going off track. One of the things that I've been doing and our team has been doing for a long period of time is identifying treatments, lung function tests to help treatments and medications, lung function tests that apply in the right condition at the right time. So spirometry or forced vital capacity is used in nearly every individual who has a respiratory condition. So COPD caused by smoking-related lung disease, cystic fibrosis, asthma, neuromuscular conditions, interstitial lung diseases, even though there is good evidence to show that that test is actually not particularly good for a whole range of those conditions, but the FDA and other regulatory bodies have said, well, we're going to use forced vital capacity. But if it's not the right test, then we should be using a different one. And so really that's what we're trying to do here. So how did we get here? I mentioned this a little bit earlier. Muscular Dystrophy WA provided a little bit of support, and then through conversations that we've been having, we've been able to create a program in which both our clinic and the neuromuscular clinic at Stanford, the Lucille Packard Hospital in California in the US, have really harmonised what we're doing. So where possible, we're now collecting clinical data in the same way. and the research measures that we're collecting in the same way. We have, I'm looking at Andrew, about 70 patients in our clinic with neuromuscular conditions, 70 to 75. Stanford University has about 300. So what we can do by ourselves would take 3 years, what Stanford University can do in 1, because they have 3 times the number of patients. The two of us together can do 4 or 5 times much more than we could ever do by ourselves. Cystic fibrosis has recognised this, and clinics have been working together for decades. For reasons that are not clear even to those of us in the field, neuromuscular clinics have not been collaborating in the same way. And so we're hoping that this collaboration will create the first seeds of a much broader collaboration across Australia and internationally. I just want to give you an example. So this was some of the work we had a student do a while ago, and we have slow vital capacity. So this is where you take a really big breath and you blow out until your lungs are empty, but we do it in a slow fashion so it's not as tiring. We measure the sniff, nasal and inspiratory pressure, so that's how well your inspiratory muscles work, and then the peak cough flow. We had, in this study, we had 35 children who did this study, and so you can see for peak cough flow, 31 of the 35 could do this test. For nasal pressures, we had 29 of 35 who could do this test, so that's pretty high. Some of these were quite young. And even slow vital capacity, only 17 of 35. So only half of the children could do this test, even though this is the test that the FDA says that we should be using. Now you can see here, for children who were receiving non-invasive ventilation, their lung function was much worse. So slow vital capacity shows differences due to disease really well, but half of the patients can't do it, which is perhaps not the best outcome. But we still see differences with these other tests, but they're not as big. Now the problem with this data is that this is one occasion. It doesn't tell us, if I see you today and the number you get today is whatever it is that going to tell us what you're going to be like in the future? And so that's really something that we're looking to focus on now. This is some work out of Stanford University. Similar things, although in this population, their measures of vital capacity were not that different in non-invasive ventilation. This is one of the new tests that we want to introduce. Adelaide mentioned the multiple breath washout test. So in this test, you just breathe in and out, and we measure, what we get you to do is breathe 100% oxygen, and so the air we're breathing at the moment is 21% oxygen and about 79% nitrogen, so that's an inert gas that doesn't do anything really. When you breathe 100% oxygen, the nitrogen in your lungs slowly washes out. So if you think about, if I can give you a reverse situation, if you've got a glass of water and it's completely clear and you put a drop of ink in it, that ink will then spread through that glass of water. So what we're measuring in this test is how well a drop of ink disperses through your lungs. If you've got muscle weakness, it takes much longer for that to happen. And so you can see here that in this measure, children who had non-invasive ventilation, it was taking them almost twice as long for the gas to mix in their lungs. Now, given that nearly all children can do this test, and we can do this in children as young as 3, we start vital capacity at 6 in the hope that they can do it by 6.5, 7. And that was their other lung volumes. So we have these tests that we think are going to be more sensitive and tell us more about what's happening earlier. So what does that mean for our study? So while we've been going for a little while, we're going to expand now. We're very lucky to have input from you, the community, as I mentioned earlier, and we have 6 members of the community who are going to be helping us. We have a researcher who's me, we have Adelaide and Andrew, and importantly we also have Piper Marsh from Muscular Dystrophy WA chairing that reference group. And so they're really there to make sure that the ideas that we come up with will actually work in real life, and to give us some feedback on this is what we want to do, this is the way we would normally do it, do you think that's going to work, how are we going to have to modify that so that we can come up with, we still need to collect certain amounts of information to be able to demonstrate that what we're doing makes differences and can lead to important changes, but there are always ways that we can change how we're doing those tests so that they don't become a burden to the point where nobody wants to do them. And so we're looking for that sweet spot, if you like, between collecting as much information as we can and not driving you crazy. And hopefully that's what we'll achieve. And we're really keen to get feedback from the community as to how we do that. And I promise you that if we get feedback, we will do everything we can to take that into account. And if we can't take it into account, we will tell you why it's important that we do that. So here are our community reference group members. Please do engage with them if you're involved in this study or in any of our other studies and you want to feed back to us. Do have a word to them or through Muscular Dystrophy WA because I know that together, just like Perth and Stanford working together, I know that us and the respiratory and neurology clinics and the community working together will lead to better outcomes. You'll have met all of our team. A few of them are sitting up the back there pretending that they're not involved, but they are. And many of you will have received emails from Jasmine over the last couple of weeks. It's not spam, so please do answer those. And she'll be the one who'll be there helping involved in this study. We have a lot of collaborators with this project, and I'm particularly thankful to Muscular Dystrophy WA for the early funding that they've given us, and really from those little things, big things will grow, and we are really confident that we'll be able to do much more with it. And from the data that we've collected, we now have two large research applications, one to the National Health and Medical Research Council in Australia, so that's the federal funding, so fingers crossed for that. Success rates aren't great, but you know, but one also with the US Department of Defense, who surprisingly also invest in neuromuscular research. And we had an expression of interest with Department of Defence, which we were invited to submit a full application, and we'll find out about that sometime in the third quarter this year, once again with Stanford University. So with that, I'll stop. We're happy to take any questions that you have now. If you want to ask questions in this forum, we will get you to use the microphone so that the video will pick them up. If you don't want to ask questions in that environment, then when we break for further refreshments, please do track down Hayley, Piper, Andrew, Adelaide or myself, and feel free to ask us anything you want. Thank you very much.
Does anybody have questions? I haven't prepared any, so I'm not going to ask any. Peter.
Sue has a question.
Oh, sorry.
No, Peter first.
Graham, did I hear you say that you thought that cough assist machines were not as effective as we perhaps believe?
No, so what I said was, and Vivian's going to tell me that I'm wrong, what I said was that we didn't have particularly good data. So there are, when you get new advances in an area, there are always individuals who so if you think about when smartphones or mobiles came in, you know, you'd walk around, most people didn't have mobiles, and you saw some people lugging their bricks. They were huge. Everybody had to upgrade their handbags so that they could fit their mobile phone in it. And so there were always early adopters with any new technology. The feedback we have in those studies is that cough assist seems to help. If you think about from the point of view of a standard of care, of a recommendation as to what evidence do we have that we could, with a high degree of confidence, give an individual cough assist and get very good benefits, I don't think we have conclusive data there, and Viv is going to mostly nod, thank you. So it's not that they are not beneficial, and I know that there's a lot of feedback from individuals that they do find it beneficial. What we don't have is the really good data to say, for this individual, this is the best setting, this is how long it should be used for, these are the conditions under which it happens. And as someone who has made a career out of trying to provide evidence to clinical teams so that they can provide treatments in the most effective way, that bugs me a little bit. And Viv?
I'm a respiratory physio, so I've got a bit of a bias to Okay, so from a respiratory, my role is to help movement of air into the lungs and movement of, of phlegm out. And the cough assist does a lot of that for very weak individuals. And the international group of cardiorespiratory physios who are experts in the field have just published 2 separate consensus statements alongside the ones that Andrew's mentioned, with a whole beautiful toolbox of all the various tools we have to help get enough air in and get a strong enough, so get enough volume in and get a strong enough flow of air out to achieve what the cough assist does for some. And it's only one machine, so we've got a whole big toolbox of other things, and the cough assist is one part of that. Yeah, I can share that on another forum.
This might be a slightly naive question, but is there any way that the sort of hospital admissions, ICU admissions, pre-cough assist and post-cough assist, even in a place like WA? I mean, in 2007, I think we had 2 cough assists. Is that right, Viv? We had 2 cough assists in WA? And now everybody who needs one has one, is that correct? So is there any way of accessing the data? So for pulling
There was an attempt, which wasn't that successful in looking and to see. There is a data from Melbourne, which did suggest that once people were prescribed cough assist, they were less likely to have hospital admissions. So there is some data. There isn't a complete absence of data. What's really clear from the studies that have been done, though, is that there's no universal way in which the cough assist is actually used. And we still don't fundamentally know whether you should use your cough assist every day or just use it when you're sick. Is that fair enough, Viv?
Yeah, can I just say something else? Even in the new guidelines, the Finkel's group, they talk about the cough assist, but please can I encourage you to talk about what the machine does. It's mechanical inexflation. The cough assist is Philips is one American company that makes it. And 3 or 4 other devices. There's the Nippy is used at Sir Charles Gardner. The Pegaso is very useful and widely used in Europe, and Queensland is purchasing that. So they have oscillatory functions. They have different NID functions you can use after. So that's just because even in the guidelines it says cough assist, but it should read mechanical inexflation, what the machine does. So we talk about BiPAP machines, but the BiPAP machine, different names for one machine. So if we can keep an open mind on mechanical inexflation, it helps blow air in, it helps suck air out, and there's lots of devices that do it. So I hope that in the years to come we'll see different devices do more particular things than just the one. So just throw that off there.
Andrew, if I can just also add, at a national level, we've been having a lot of conversations with Philips around some investment from them into some research around the benefits of the cough assist machine, because we've got a fleet of 62 of them, which took a lot of it. I mean, they're expensive machines. They're near on $10,000 for a machine. So I guess the expectation for us to keep building this resource of cough assist machines, we actually need them to do some work for us as well. So that's something that we are driving at a national level. But it's good to know there are other companies we can approach too.
And we are looking at use of cough assist in our study. That's one of the clinical outcome measures we're looking at, whether people use it.
We are looking at whether people enrolled in our trial use cough assist, and looking at things like respiratory infections to see if we can relate that back to their lung function and things like hyperventilation. So if anyone wants to give us money to do more stuff with cough assist, feel free.
Shameless plug. Are there other questions at all, or would you all like some refreshments and an opportunity to ask them in a more one-on-one environment? Okay, I'll take that as a yes. So thank you all very much for paying attention. It's been great to have you here, both engaging with the hospital clinic and with Telethon Kids. Please do feel free to stay. We have more refreshments available, and thank you very much.